We've got actually a lot of questions to get through. It has certainly generated a lot of interest. But Ivan, is it wise to return to sport after an ACL reconstruction operation?
Well, that's the question. I mean, the purpose of that talk was often that return to preferential level of sporting activities is the basis that people undergo ACL reconstruction. Whether in fact is actually wise to is a different question. If you look at most long-term studies of ACL tear patients, regardless of treatment, 50% develop osteoarthritis within 10 to 15 years. So at the time of the ACL tear, it's generally half the patients sustain significant articular cartilage injury, usually at the microscopic level, and they subsequently develop long-term degeneration. So from a knee long-term survival perspective, it's probably not. But, you know, athletic activity is an important part of people's life, so it's sort of a decision that they need to make.
Mm-hmm. So I'd just like to comment, I'm a holistic orthopaedic surgeon. I don't just take care of the fracture, I take care of the whole bone, and that applies as well with the ACLs. So my personal perspective is when you put these people through a proprioceptive retraining program like the FIFA 11 Plus program or the PEP program, a lot of that is actually directed to fixing a lot of those issues that you were talking about. And I have to say, since starting that a number of years ago, I think the results have been far better. And also, you know, the proprioceptive retraining pre-injury or for sports generally has reduced the ACL injury rates. Yeah. Andreas, did you want to make a comment there?
Yes, I'm sorry, Doron, but I hate to contradict you. If you look at the figures for re-rupture rates, whether in fact the same knee or the other knee in young males who had ACL reconstructions, it's actually on the whole a failure of what we do for them rather than providing them with any benefits. The re-rupture rates are so high, there has to be a change in behavior. We have to affect that and not simply look at return to sport, especially the same sport, as a positive outcome measure. Yeah, I think it's actually a failure if they go back to the same sport where they had the injury in the first place.
Okay, but if you just look at the re-injury rates though, if you look at the FIFA studies, this is the only thing FIFA has ever given away for free in its entire life. They spent several $1 million designing this program, doing it it was designed for school and college age students to try and prevent ACL injuries in soccer. And the data is actually out there. It's very clear that the injury rate dropped from nearly 10% to nearly 1% doing this proprioceptive retraining program. So be that as may, you know, perhaps had they done that in the first place, they wouldn't have injured their knee. So it's not a great idea for them to go back to sport. But what if it's the person's livelihood? Or, you know, what if they're earning all of their money doing this and they don't have any other skills or training?
I think that's entirely understandable then. It's like coal miners going back down in the coal mine where there's a very high risk. I accept that, but that's not what we should be looking at as an outcome measure, let alone a positive outcome. It's a philosophical question, really, because the ultimate figures on re-injury are very high.
All right, while we're talking about philosophy, what have been the most significant changes which have led to better outcomes from the registry, Andreas?
I think one of the big issues was dislocation rates in the past, and a very clear message is that using bigger heads has led to a much lower dislocation rate. So now we used to have 22 millimeter and 28 millimeter. Those are virtually unheard of now. We're using 32 and 36 and sometimes 40. And so that's a very clear message from the registry. The other thing is that even though in younger patients uncemented prostheses are good, but in older patients, the over 70, uncemented femoral components are no good. So these are things which we've clearly learned over the years, apart from the metal on metal disaster, which was probably a short-term problem with one or perhaps two particular prostheses, but those are things which we learned through the registry. In fact, it was the Australian registry, although it was a prosthesis used around the world, the Australian registry was the first to pick up the fact that there was a problem with the ASR. I'm disappointed to say that the mechanism wasn't very good. The registry was good. The registry sent 17 letters to the TGA before the TGA actually withdrew the prosthesis. So there are administrative things which others also have to learn, such as the regulators.
All right. Ivan, which are the non-weight-bearing donor site areas for oats, and what happens to them in the long run? Because surely if there's articular cartilage there, you need it.
Well, we basically harvest the donor sites from. I mean, obviously it's limited, but you can take it from the inside of the medial and lateral femoral condyle, where the condyle curves around, which is non-weight bearing. You can take it from the extreme lateral flange of the trochlea and extreme medial flange of the trochlea. You take the bone that you take out of the donor site, you then put that in to minimise the depth of the hole, and the whole thing's filled in with fibrocartilage. Yeah, and generally they don't seem to cause any issues. I mean, you're looking, these patients are not people with asymptomatic knees that have, serendipitously found a full thickness defect at the time of arthroscopy. These are people with who have been through a whole gambit of non-operative management and still having significant pain. Whether the procedure or the operation of the donor site sets up some chain reaction, the articular cartilage, I'm doubtful. I think that they probably tends to be relatively well localised. But they, in my experience is they do very well. Although like follow-up in most of these people, it's about 5 to 10 years.
Yeah. So Ivan and I differ slightly in that I do very few oats procedures. I look at doing either unloading osteotomy or one of these other cartilage transfer procedures. I'm not a big fan of oats because my theory is that you're taking relatively thin articular cartilage, which is at a different shape and angle, and putting it somewhere where it's not meant to be, whereas there are, in certain series, good results. So the thing about this is that it's a very difficult area and we don't have decent results. Coming back to the rehab, we can start with you, John. Do you think hydrotherapy is useful or even necessary for people after having had this sort of surgery?
We're talking about oats or cartilage surgery?
Any type of cartilage surgery, osteotomy, even joint replacement if you like.
First of all, good morning everyone, and thanks Doron for all your work. Being a recipient of a hip replacement at age 44, hydrotherapy was part of my rehab, and certainly one of the benefits for hydrotherapy, which I think most of you know, is it's generally a safe and painless way to move. And I think with post-operative pain, where, as Ivan had described, and it's good to hear a surgeon talking about that, the inhibition people have and the lack of confidence and uncertainty that occurs in the rehab can be minimised with hydrotherapy. I think the problems with hydrotherapy is the programs that are created. So I think if you're going to look at being a hydrotherapist and using water, I think having a structure to it, and if people are going to the trouble of going somewhere and getting wet, you want them to spend at least 20 minutes in the water. So if you're going to do that, I think a 20-minute program, which depending on what you do, obviously will look at range and then weight bearing in different proportions. What I say to patients, particularly if they're post-ACL, for example, or post-knee replacement, I say to them, once you're waist deep, you've taken over 50% of weight off your knee, and therefore it's a lot easier to start on closed chain movements, so squatting programs with double leg, single leg. So the short answer is absolutely, but not everyone likes water, and if you've got patients who are obese, they may not be confident wearing a swimsuit somewhere public, so you need to be a bit sensitive about that with them also. But it's useful. And just to sort of touch on one last thing, with regard who returns to sport following ACL, My rule of thumb for people once they hit 35 or 40, I say the same thing now. I say you're going to get pain somewhere, so you need to be able to do more than one sport. So someone who's focused on playing games whilst running really needs to do something else. They need to be able to ride a bike or choose to swim or paddle or box or do something else. And it's a good life rule. And often there's a pleasure that comes with that takes the pressure off returning to that impact and change of direction sport if it's not their occupation.
Ivan, is something you routinely do, hydrotherapy, when they're in the non-load-bearing phase?
Normally with joint replacements more than ACL reconstructions.
Just speaking to the mic, please.
With joint replacements, definitely. I haven't used it as a preferred modality with ACLs, but I've got no problem with people using it.
Now, Andreas, there was a recent review that showed there was actually no benefit to inpatient rehabilitation after joint replacement, that the outpatient therapy worked just as well without hydrotherapy. Have you got any comments with that? Does the Joint Registry look at anything after they've actually had their operation?
No, the registry doesn't look at that, but I think we have a lot of figures. The most interesting figures which recently came out were, for me, the most interesting were from Medibank Private. They put together basically the data on all surgeons in Australia. So 20% of surgeons send every patient after hip replacement for rehabilitation, and 20% send none for rehabilitation, and everybody else is in between. But we haven't yet seen any outcome studies on that. So do the patients who go to rehab do better or not, or outpatient, inpatient? This hasn't been studied, to my knowledge, sufficiently, because it's quite a heterogeneous group. The other thing in our practice, in my practice here in the eastern suburbs, it's amazing how many patients want to go to rehabilitation. They want to have another holiday. So, and it's...
Holidays are good, Andre.
And yes, I'm not arguing with them, but I'm saying that the reasons why people go is quite varied. Are we talking about people who live on their own? Because we have an increasing number of people who in older years live on their own, and they need or they want the extra benefits. It's a complex area. I don't see any downside apart from the costs.
Ivan, this is sort of a loaded question. If someone has had oats, how long is it before they're allowed to go back and play sports?
Generally, when the knee's pain-free, they've rehabilitated their muscles adequately, had a proprioceptive retraining program, and the knee feels normal. So generally about 3 or 4 months.
So the reason it's a loaded question, if they've stuffed their articular cartilage, doing any impact loading sports is a really, really bad idea. So sports like cycling or swimming are fine, and they can do that fairly early.
Yeah, ideally, but I mean the reason you're doing oats is actually restoring the articular cartilage architecture. So the loading capacity is far better than the techniques which get a fibrocartilage, which doesn't tend to last long. So that's generally the principle behind oats. I mean, I get what you say. If you've had any articular cartilage or any significant knee injury, is it sensible to return to impact sports? The answer is going to be no. But I mean, generally these people can, and they generally do very well returning to sport. So I had, again anecdotally, but I had a patient had a full thickness lesion at 22, and I did an oats procedure, and he's now in the Australian triathlon team. So you can get very spectacular results with that. Whether it's a great idea long term, it's another story.
Those are, again, N=1 studies rather than true science. Because most
no, it's not the only patient. I've had plenty of patients return to high levels of sport.
But generally speaking, if you look at hundreds of patients, generally speaking, long term, they all get arthritic changes.
Well, they've had articular damage to their joints, yeah. So But people make their own ideas of how they're going to live their life. If people returning to sports is very important for them, that's a major goal, and that's what makes them happy. You discuss this with the patients, and they make their own decisions about how they want to live their life. It's not up to us as orthopaedic surgeons to determine how they live their life.
That's true. Andreas, why were so many metal-on-metal prostheses used?
There's a lot of history, and if one looks, in fact, at some of the graphs I showed about the polyethylene wearing, namely the old polyethylene, there was a real problem, and we used to do a lot of revisions because the old polyethylene wore in such a way that tiny little particles came off and gave a foreign body reaction around the joints. So early on there was definitely a need to explore other areas. Ceramic on ceramic has been around, and of course people tried to develop better materials, and that's where metal on metal came about. Metal on metal itself is not new, because there was an old metal on metal prosthesis, which the McKee-Farrar, which was around for many years. Why were so many used? Because company pushed this. The big company at the time, DePuy, pushed this metal-on-metal prosthesis as their number one solution for all and sundry, and it took a while to show that there was a difference. There was also a problem with the introduction of the prosthesis, because in the American system it was seen to be so similar to others that they accepted the results of the Birmingham and just transferred them to the ASR, but actually the material was different and the tolerances were different. So a lot has been learned from this catastrophe, and the regulations about introducing new prostheses have been tightened up a great deal.
There's several questions here basically on the same topic. Does the registry record the approach? So for example, anterior approach versus posterior hip approach for hips, and can we see a difference in the revisions or survivorship based on something like anterior versus posterior approach?
The registry has only recently started to record the approach, but one of the statistically speaking, the anterior approach was actually introduced by one company, and so one can look at the Quadra H, which was all put in through an anterior approach, and the registry figures for the Quadra H are very interesting because there's a very steep learning curve, and with the learning curve there were actually probably quite a lot of unnecessary revisions in the early stage. So yes, one can do that indirectly. Now we do record the approach, but that is only relatively recent. For most of the 500,000 cases, the approach was not recorded.
All right. There's a question here on when would one do a tibial osteotomy versus a femoral osteotomy, and that mainly depends on where the deformity is. If you've got a valgus deformity, generally you need to deal with that at the femur. If you've got a varus deformity, generally speaking, you can deal with it at the tibia, but you have to work out exactly where the deformity is and correct it as close to where the deformity is as you can. Ivan, ratio femoral versus tibial osteotomies for you?
I haven't done a femoral osteotomy since I've been in practice.
Okay. Andreas?
It's rare. I would say it's 50 to 1.
50 to 1? Yeah, I think that's probably it may be closer to 100 to 1 for me as well. All right, very good. Is there an optimal age for a total knee or total hip replacement, given that the prostheses are lasting longer and the revision rates are lower? So, John, yours was done at how old?
It's so I was. This is a quick case of a 44-year-old sports physician who was born with dysplastic hips. So the men in our
and
family.
What did your surgeon tell you? How long did he tell you your prosthesis would last?
It depended what I did with it, so that was very important. So whether you like it or not, any prosthesis has a lifespan, and it's dependent on a few things, but basically the cycles of impact and body weight are two key factors. So one of the things I had to basically say to myself is I'm going to restrict how much running I do. So in terms of the question, it's very much, I think, a lifestyle decision, and there are different criteria for that. So in terms of quality of life, pain and ability to move and to do the basic things are the criteria when you're having discussions with the patient. And it's a real journey you're going on with them. And a lot of people have had friends who have felt so good after joint replacement, particularly hip replacement, that they're wanting to go to that a little bit earlier, whereas I think with the knee, people are wanting to put that off as late as they can. With regard to how long it lasts and so on, I'll leave that to Andreas, but in my own experience, I'm 9 years down the track after having a Birmingham, which is a metal on metal. I have my metal irons checked about every 3rd year. I didn't have any complications. I don't really know it's there, apart when I travel, which is a problem, because if I haven't shaved, I'm the man of Middle Eastern appearance. I was born in Egypt, which is on my passport, and I'm setting off metal detectors, which is not good.
Andreas?
Well, I think, John, it was actually a loaded question because yours will last forever because you're a physician. Surgeons much more active, it would be much more difficult to predict. So in general, the prostheses are lasting long, and John is quite right. John actually fits into the category where the Birmingham is indicated in a small group of young active men with good bone stock, and without AVN, the Birmingham still has probably the best results. So that was a correct choice for you. And the chance is that it will actually last forever because the wear rates of the Birmingham are so low that unless you have a fracture of your femoral neck, which could happen in your old age, otherwise the prosthesis itself should actually last your lifetime. And there are a number of other prostheses now where we project that on the basis of wear, they should last a lifetime. Ceramic on ceramic, as well as the new polyethylenes, have such good results that really we can tell patients, unless they fall, have infections or the other reasons, but from a wear point of view, there are many prostheses, many hips which should last a lifetime. The knees, not quite so much.
Yeah. Ivan, can you do a cartilage graft without a high tibial osteotomy?
The Oates graft, yeah. I mean, that's one of the... Well, I mean, if you've got someone with, generalised unicompartmental articular cartilage wear, you're dealing with a different population group to the group which has got an isolated chondral lesion with normal alignment. So I mean, in that first group, then you're looking, you're probably looking at an H2O anyway, regardless of what you do, the articular cartilage.
Yeah, so that's the key, isn't it? If their alignment's normal and it's an isolated injury to one articular surface, then you don't need to change their alignment, you just need to restore their articular cartilage.
Yeah, I mean, that's the indication for the isolated Oates in a nutshell, yeah.
Now, something that I do occasionally is I'll actually get a valgus unloading brace. It's got a built-in elastic component to it, and if I'm not correcting their alignment, I'll put the patient in a valgus unloading brace for up to 3 months just to try and actually take the pressure off that area that I've grafted. Again, I don't know that there's any necessarily science behind it, but in my mind, I think if it helps unload it a little bit in the early stages, it can help the healing process.
I think that's a great idea, and I also think it's worth trying an unloading brace when you're considering high tibial osteotomy and unicompartmental degeneration, because that mimics the osteotomy. So if a patient gets relief in their offloading brace, they'll be a good candidate for an HTO. If they don't, then you probably have to think twice about performing that procedure.
And I'm just going to finish the panel up with a question. We're going to ask this for each panel. Andreas, because I know that you'll speak very candidly. No, that's not the reason. PRP or stem cells in the hip or knee, any role to play?
I haven't seen the scientific evidence.
Ivan?
Well, for stem cells to work, you need the extracellular matrix for them to differentiate along a particular cell line. So for stem cells to work to reconstruct articular cartilage, you need the collagen framework intact. Part of the degenerative process is you just get destruction of that process, that extracellular matrix. So stem cells can't work, which is silly. PRP, I haven't seen very clear evidence of any effect. People talk about modulating inflammatory mediators. I think it's unclear at this stage.
There are some studies looking at PRP for knee arthritis in terms of temporary pain reduction, but there's no regeneration there. Please bear in mind if your patient has osteoarthritis and is going to need a knee replacement and they've had lots of injections in their knee, there's an increased risk of introducing infection, which will delay the surgeon's decision to operate on them. And if they get an infection, they may not ever be able to have a knee replacement, or it'll be delayed some years because of the risk of complications with that. So and for stem cells, no evidence still.
So the placebo effect is very strong, and if you've paid $9,000 for an injection, you're likely to have a fairly strong anecdotal response, and you're going to tell people that you felt better even if you don't. I know a lot of the horses, the vet studies, the horses definitely seem to walk better, but I think it's because they've had the liposuction and they're sort of proud about how they look.
But they still have a long face. They're very sad.
A very long face. I hope you like the tag team there. So just a couple of housekeeping matters. If you brought a cup of tea or coffee with you, please take the cup out with you. The men's bathrooms are out to the left side, the ladies' bathrooms out to the right side. Please go and have a look at our sponsors, and we'll reconvene in about half an hour.